You can join with your computer audio and put yourself on mute and your video as well. And then we're asking everyone to display your name and your pronouns as well, please. So firstly, this session is going to be recorded. Sierra's just started that and will be distributed to those who registered for this session today. So welcome to the decision support tool updates for RNs and RPNs who diagnose and treat opiate use disorder. My name is Sally Coop, and I'm the program manager for education and implementation at the BCCSU. And I'm pleased to be joined today by Ashley Gray, who will be doing our presentation. A bit of housekeeping. Your feedback's important, so at the end, we'll follow up with a link for feedback along with the recording of this session. If you have any questions throughout, you can post your questions in the chat, and we'll have a Q&A at the end, so please hold off till then, and Ashley will coordinate that. If possible, we encourage you to put your video on during the Q&A, and feel free to use your raise the hand function and then unmute to post your question. Before we start, I'd like to state that we respectfully acknowledge the land on which we're hosting this session is the traditional and unceded and ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh people. We recognize that the ongoing criminalization, institutionalization, and discrimination of people who use drugs is disproportionately harming Indigenous peoples, and that continuous efforts are needed to dismantle colonial systems of oppression. We see our work here connected to the efforts and hope that the BCCSU program and our education contributes to an addiction system that provides safe, respectful, evidence-based care. I'd like to note that most of you are joining from nation territories, so I encourage you to take a moment to share where you're joining from and the lands you're on in the chat. Thank you, and I'll now hand off to Ashley Gray. Oh, sorry, Ashley, your mute might still be on.
No hearing.
Can you hear me now?
Yes. Yeah.
Okay. All right. So our agenda is the updates in the buprenorphine, naloxone, and methadone and SROM decision support tools. Our learning objectives include understanding the key updates to the buprenorphine naloxone DST, conduct a low-dose buprenorphine naloxone induction with a temporary co-prescription of SROM or methadone, understand the key updates to the methadone and SROM DST, initiate methadone or SROM, and apply updated dosing, titration, and missed dose protocols to methadone and SROM prescribing. So as of November 22nd, 2023, we have released updated versions of the decision support tools for registered nurse, opioid use disorder certified, and registered psychiatric nurse, opioid use disorder certified prescribing of buprenorphine, methadone, and slow release oral morphine. The updates to the DSTs focus primarily on translating new updates from the opioid use disorder guideline and expanded scope of practice for RNs and RPNs that authorizes initiations of methadone and SROM, among other changes that we will review today, in addition to updated language to reflect the transition to certified practice designation as of November 1st, 2023. So the decision support tool updates for certified practice, opioid use disorder, RN and RPN prescribing of buprenorphine naloxone. So there's several new updates that you can see. We'll be going over all of them in more details. So we've really tried to divide up the complex and severe acute or chronic illnesses that are out of scope for certified practice OUD, RNs, and RPNs, and those that they must consult or refer to a physician or NP depending on clinical stability of the client. So some examples that you can see here include cardiac conditions, arrhythmias, unstable angina, CHF, GI conditions such as bowel obstruction, suspected surgical abdomens, respiratory conditions such as acute asthma or pneumonia, hepatic conditions such as cirrhosis and acute hepatitis, sepsis, and severe CNS conditions such as brain tumors and recent head injuries. The DST updates include one new sample low-dose induction protocol. So depending on client preference and lifestyle, the consistent twice daily dosing may work better for some individuals. The updated DST includes a decision support tool for selecting an OAT medication. The table outlines some important information of each OAT medication, such as initiation, retention and treatment, safety, and side effects. Prescribers can use this tool to help decide with the client which OAT medication is appropriate for them. At this time, extended release buprenorphine or Sublocade prescribing is out of scope for certified practice OUD nurses. To prevent precipitated withdrawal in traditional inductions, prescribers should ensure the appropriate amount of time has passed since the last opioid use. Clients who may be at higher risk of precipitated withdrawal include individuals who use fentanyl. These individuals may receive a total starting dose of 2 milligrams of Suboxone. Clients at lower risk of precipitated withdrawal include individuals who have recently completed withdrawal management, who have been recently discharged from an inpatient setting, or known time of last opioid use or fentanyl negative urine drugs test. These individuals may receive a total starting dose of 4 milligrams. If clinically indicated, co-prescribing of full agonist, example methadone or SROM, during low-dose inductions can help reduce or eliminate a client's reliance on the unregulated drug supply and reduce the risk of drug poisonings during titration. Certified practice opioid use disorder registered nurses and registered psychiatric nurses must have completed the full BCCSU Provincial Opioid Addiction Treatment Support Program, POTS-P, authorized RN and RPN education and training pathway to prescribe buprenorphine, naloxone, methadone, and SROM, and be authorized by BCCNM and their employer prior to prescribing a full agonist. The full agonist dose, either methadone or SROM, is dependent upon the client's tolerance. Suggested doses can be found in the decision support tool for registered nurse opioid use disorder certified and registered psychiatric nurse opioid use disorder certified prescribing of methadone and slow release oral morphine. This table is a sample of a full agonist co-prescription for an individual with a known high tolerance. Certified practice opioid use disorder RNs and RPNs who have completed the necessary education and training may now prescribe either methadone or SROM with a low-dose buprenorphine naloxone induction for a maximum of 7 days. The day 1 maximum of buprenorphine naloxone is 16 milligrams. Previously, the total daily maximum dose for buprenorphine was 24 milligrams and has now been increased to 32 milligrams. However, some individuals with a high tolerance may require doses above this. If a client requires a dose above 32 milligrams, they must be referred to an MD or nurse practitioner. Options for managing precipitated withdrawal that are within scope for CP-OUD, RNs, and RPNs include continuing induction, delaying induction, and stopping induction. There is a new option to manage precipitated withdrawal, and it involves treating it with additional doses of buprenorphine naloxone in close succession. The additional doses typically range from 8 milligrams to 16 milligrams. This option is out of scope for CPOUD RNs and RPNs, but included in the DST so clients are aware that this may be an option for people receiving care. If clients wish to use additional doses of buprenorphine naloxone to manage their precipitated withdrawal, they must be referred to nurse practitioners or a physician. There's some new guidance on safety considerations that nurse prescribers should be aware of. For example, driving during OAT initiation and titration. While there is mixed literature in individuals receiving OAT and impaired driving, prescribers should use their judgment and consider each situation on a case-by-case basis. There is some new guidance on OAT and driving. The resources for policies, standards, and bylaws on practice standards, confidentiality, and the duty to report have been included in the new DST. CPOUD, RNs, and RPNs are encouraged to consider these resources if they are concerned about someone driving while on OAT. Now, the decision support tool updates for certified practice opioid use disorder, RN, and RPN prescribing of methadone and slow-release oral morphine. So again, here are the new updates to the methadone and SROM DST. We'll be going into more detail on those. Again, this complex acute or chronic illness assessment table also applies to methadone and SROM DST. It is now within the scope for CPOUD, RNs, and RPNs to initiate methadone up to 40 milligrams and SROM up to 300 milligrams for clients with OUD, given the prescriber meets the competency requirements for prescribing. However, there are still some limitations with initiations. New scope expansion for methadone initiations for CPOUD, RNs, and RPNs. So you may now initiate methadone for individuals with OUD. So you must prescribe within your scope if clients have acute or chronic comorbidities, severe hepatic or renal dysfunction, etc. CPOUD, RNs, and RPNs must refer or consult based on box 1 in the DST. We've also made it clearer in the DST that bridging prescriptions without an assessment of the client is out of scope. Certified practice OUD, RNs, and RPNs can only prescribe if they have done a virtual or in-person assessment, or if the client is known to the prescriber and or is being assessed by another healthcare provider. CPOUD, RNs, and RPNs must refer if the initiation dose is greater than 40 milligrams and must consult with a physician or nurse practitioner if the methadone prescription is over 150 milligrams. Selecting a starting dose of methadone is based on the client's opioid tolerance. Individuals with no or low opioid tolerance are at a high risk of toxicity. This includes those who have just completed withdrawal management, those who are not currently using opioids but at risk of using, heavy use of sedating agents, and those who have severe comorbidities that affect toxicity risks. It is suggested that these individuals be started at 5 to 10 milligrams per day. Individuals with unknown or moderate tolerance have a moderate risk of toxicity and includes individuals who use benzodiazepines, either prescribed or non-prescribed. It is suggested that these individuals are started at 10 to 20 milligrams per day. Individuals with known high tolerance include those who are actively using opioids. It is suggested that these individuals be started at 20 to 30 milligrams per day. And finally, individuals with a known very high tolerance to opioids include those who have previous methadone experience and current fentanyl use. It is suggested that these individuals be started at 30 to 40 milligrams per day. Individuals who require a starting dose greater than 40 milligrams should be referred to a nurse practitioner or physician. New scope expansion for CP, OUD, RNs, and RPNs. So they may initiate SROM for individuals with OUD. Certified practice OUD, RNs, and RPNs must prescribe within their scope if clients have acute or chronic comorbidities, severe hepatic or renal dysfunction, etc. CP, OUD, RNs, and RPNs must refer or consult. Bridging prescriptions without an assessment of the client is out of scope. Certified practice OUD, RNs, and RPNs can only prescribe if they have done a virtual or in-person assessment, or if the client is known to the prescriber and or being assessed by another healthcare provider. Certified practice OUD, RNs, and RPNs must refer to an MD or NP for initiation doses greater than 300 milligrams. Starting doses of SROM are based on the client's opioid tolerance. Individuals with no or low opioid tolerance are at high risk of toxicity. This includes those who have just completed withdrawal management, those who are not currently using opioids but are at risk of using, heavy use of sedating agents, and those who have severe comorbidities that affect toxicity risks. It is suggested that these individuals be started at 50 milligrams per day. Individuals with unknown or moderate tolerance have a moderate risk of toxicity and includes individuals who use benzodiazepines, either prescribed or non-prescribed. It is suggested that these individuals be started at 100 to 150 milligrams per day. Individuals with known high tolerance include those who are actively using opioids. It is suggested that these individuals be started at 200 milligrams per day. And finally, individuals with a known very high tolerance to opioids include those who have previous methadone experience and current fentanyl use. It is suggested that these individuals be started at 300 milligrams a day. Individuals who require a starting dose greater than 300 milligrams should be referred to a nurse practitioner or physician. Gradual transitions between methadone and SROM must be referred to a physician or nurse practitioner. Rapid transitions between methadone and SROM are within scope for CP, OUD, RNs, and RPNs with consultation. A more conservative ratio may be appropriate depending on the client, and this ratio should be determined during the consultation. Dose escalations are dependent on the client's level of tolerance. Prior to dose escalations, the individual must be assessed, either in person or virtually. Titration dose and frequency is based on clinical discretion, client preference, and intensity of cravings and withdrawal symptoms. Certified practice OUD, RNs, and RPNs must consult an MD or NP if the methadone prescription is over 150 milligrams daily. Prior to dose increases with SROM, the client must be assessed, again, either in person or virtually. The clients must have tolerated the previous dose and have had no drowsiness post-dose. Dose escalations may be considered for individuals who present with cravings, withdrawal symptoms, or ongoing non-prescribed opioid use. Doses may be increased by up to 100 milligrams every 24 to 48 hours. There is no defined maximum dose for SROM. Certified practice OUD, RNs, and RPNs must consult a nurse practitioner or physician if the individual is prescribed over 1,500 milligrams daily. Now we'll go into some missed dose protocols. So for methadone, tolerance is lost quickly when methadone treatment is interrupted or discontinued. If clients miss 1 to 3 consecutive doses, there doesn't need to be any dose change. The rest of the suggestions are just average dose reductions. For individuals whose risk of lost tolerance is assessed to be lower, for example, those who have continued using other opioids since last methadone dose, A smaller dose reduction may be considered after individualized assessment of risks, benefits, and safety considerations. On the other hand, a more conservative dose adjustment schedule may be considered for individuals who have not used unregulated opioids since their last dose. These are, again, average dose reductions. Some individuals may require a smaller or greater dose reduction depending on individual circumstances. If 4 consecutive days are missed, the client may resume at 50% of their previous dose or at 30 milligrams, whichever is higher. Reasons for missed doses should be discussed and documented, and a discussion regarding barriers to medications should be had. If 5 or more doses are missed, methadone should be held pending virtual or in-person assessment of the client. The remainder of the prescription should be canceled. Reasons for missing doses should be discussed and documented with attention to supporting the client for better OAT retention. If 5 or more consecutive days are missed, restart the client at 30 to 40 milligrams, depending on client tolerance. Now we will review the missed dose protocol for SROM. So the short half-life of morphine results in the potential for rapid loss of tolerance and the possibility of harmful oversedation. For individuals who have missed 1 to 3 consecutive doses, resume without dose reduction. For individuals who have missed 4 consecutive doses, resume with 50% dose reduction or return to initiation dose of higher. These are average dose reductions. Some individuals may require a smaller or greater dose reduction depending on individual circumstances. Refer to a nurse practitioner or physician for a smaller dose reduction. For individuals who have missed 5 or more consecutive doses, restart the individual at the initiation dose. For methadone prescriptions, CP/OUD, RNs, and RPNs must consult a nurse practitioner or physician if the dose is over 150 milligrams. A referral must be made for initiation doses greater than 40 milligrams. For SROM prescriptions, CP/OUD, RNs, and RPNs must consult a physician or nurse practitioner if the dose is over 1,500 milligrams. A referral must be made for initiation doses greater than 300 milligrams. So a bit about take-home doses for methadone and SROM. Due to their inferior safety profile, methadone and SROM have more restrictive considerations compared to buprenorphine naloxone. The rationale, along with the criteria being met, must be clearly documented. The prescriber must ensure that take-home doses are safe for both the client and the public, as unsafe storage, non-prescribed use, and diversion may lead to lethal consequences. Again, some safety considerations. So there's new guidance on OAT and driving. The resources for policy, standards, and bylaws on practice standards, confidentiality, and the duty to report have been included in the new DST. Nurse prescribers are encouraged to consider these resources. If you have completed the POTS-P for RN and RPN prescribing of methadone and SROM and the necessary preceptorship, no additional formal education hours are required for this round of DST changes and scope expansion. Anytime a new skill or activity is added to the DSTs, the BCCNM expects certified practice nurses to engage in education to gain competency in this new activity prior to engaging in the new activity, i.e., prescribing a new medication. For this round of scope expansion, this will not be tracked by the BCCSU or BCCNM and is the individual nurse's responsibility to undertake and ensure their own competency. To support your learning needs, This webinar, along with an additional optional learning supplement, have been made available to help you develop competency in the new activities under the updated DSTs. For future scope expansion, example, if prescribed safer supply or Sublocade were added to the scope of practice, there may be required formal education and preceptorship time. Please be aware that your employer can further limit but not expand the scope of practice of nurse prescribers, CP, OUD, RNs, and RPNs. Please check with your employer around any additional required education or limits on practice prior to implementing any of the changes in this DST. Finally, I just want to let you know that tomorrow there's a provincial webinar for opioid use disorder guidelines from 12 to 1. And that will be co-presented by Guideline Committee co-chairs Dr. Back and Emma Gurad and Dean Wilson, the BCCSU Peer Engagement Lead, for an overview of key practice changes and updated recommendations from the forthcoming guideline. I just want to let you know about these resources. So as always, there's the 24/7 addiction medicine clinician support line, the BC Echo on substance use, and the addiction care and treatment online course. And then that concludes the information on the new DSTs. So we'll open it up for questions and discussion.
Yes, Amanda, you can ask your question.
Hi there, Ashley. I was just I had reviewed them with our team, but is there an official, I know that the evidence in the clinical guidelines doesn't state it, but is there an official maximum dose of SROM and methadone? Like I know we have that definitive, 32 milligrams equals refer for buprenorphine naloxone, but it's not actually clear around a max dose. It just says consult, which I think is a little bit of area of discomfort or confusion. Are we able to just clarify that?
Yeah. So for RNs and RPNs, the maximum dose of SROM is 1,500 milligrams. So that hasn't changed. And then the new opioid use disorder guidelines really haven't stated a maximum dose. It's been like this the entire time I've prescribed out. But I think realistically, I've heard like kind of in the 2000 range is usually the highest, 2,500, somewhere in there. I don't know if you want to comment, Paxton, but certainly I think that's up to clinical decision makers and outside the scope of RNs and RPNs, but that's what I've seen in my practice.
Yeah, I can chime in just on the background of that, Ashley. So the reason that there's a maximum dose for buprenorphine is with bupe specifically, there comes a certain point beyond which essentially all of your opioid receptors get saturated, and so anything beyond 32 milligrams of buprenorphine is any additional. There's certain patients here and there that sometimes benefit from slightly higher doses than that, but I think it's really diminishing returns. With full agonists, there really is no maximum. So there's no firm ceiling on it, although we've sort of, the 1,500 and 150 is somewhat of an arbitrary upper limit, beyond which, certainly there are some patients who need higher doses than that. But I think you start to need to get very thoughtful about increases beyond, somewhere around that point, and really asking kind of what benefit you're expecting to see with those increases. Because as I'm sure you've all seen, there's some people who will continue to have some use, and no matter what dose of oat you have them on, that may persist if you're not speaking to the reasons they're continuing to use. Sometimes it's not about an opioid deficit, it's something else. And so that's sort of a somewhat arbitrary threshold we put in place, beyond which I think you really need to start being thoughtful and about dose increases, in collaboration with your patient and what you hope to benefit. But certainly I've seen people who are into the high 200s on methadone and still seem to obtain some benefit with those increases. They're few and far between. But there really is no, from a physiologic standpoint, we can't put a hard ceiling on that.
Does that answer your question, Amanda?
Yes, thank you. So ideally, a nurse prescriber could prescribe over 150 milligrams of methadone, but it should be in consultation and, as you said, kind of far and few between and done very thoughtfully.
Exactly. Tori, you have a question?
Yeah, hey. I'm wondering if we can put that link to the webinar that is for tomorrow. Can we put the link into the chat so people can register for it? And I feel like I've seen them, but I don't know where I'm finding them. Just updated DSTs for RNs regarding this. Is there one, or is it kind of still the same like boxes and stuff that we've had?
No, there are 2 new PDFs.
Yeah.
Most of them have been like pushed out via email. When I went on the website, the old one had been like shut down and they haven't
Right.
replaced it yet.
Okay.
So I don't know what the timeline for that is, but
Okay.
I can certainly recirculate that for
Please.
the north.
Yes, thank you.
Yep.
That's it. Thanks.
Christy?
Hi, yeah, thank you. So just, and I didn't do a really close dig, but you mentioned there's a max day. So if you're doing a microinduction of 7 days of co-prescribing the methadone or Restom along with the buprenorphine. If you're doing a slower microinduction at say over 10 days, which I typically kind of do, is there any room with that, or is it kind of like a hard and fast 7 days? Okay.
Well, I think the 7 days is to help you get to longer, because really you should be stopping their full agonist opioids before you're at the max dose of your Suboxone. So if I'm doing a 7-day induction, I usually stop at least a day beforehand.
Yeah.
So
just in like those instances where, you know, there's kind of struggling and you're kind of trying to drag it out a bit, but we're still limited.
Yeah.
Okay.
I'm going to say there is no wiggle room on that.
Yeah. Okay. Sounds good. Thank you. And then just one other quick question. So for the consult over the 1500 and then the 150, do we need to consult every 4 weeks? If somebody's at a stable dose at 160, is that like ongoing?
Yes, I get this question a lot from nurse prescribers, actually. I think it's honestly from a prescriber's perspective that I want to know when there's changes. So I think if your client changes and if the dose changes, then that needs to be the consult. If everything is the same, I think that you have to have that relationship with whoever you are consulting and referring to within your community. But I think most prescribers would say the same. If everything is status quo, it's probably okay to continue.
Perfect. Sounds good. Thanks.
Natasha?
Hello.
Hi.
So I had a couple questions. So what is the guidelines regarding people missing appointments? So when a person misses their appointment and has been picking up their prescription every single day because it's a witness in the pharmacy and they don't know, maybe they don't know or they forgot they had an appointment. What do you recommend? Like, I've been letting people just run out and I feel bad because they're missing doses. And I know physicians can continue the prescription, so I don't know.
Well, within the guidelines we presented, you can have a virtual appointment with them. So if you can get them on the phone and put them in that way, I think that's a reasonable way to do it. And also it says if they're having an assessment by another healthcare provider. So thinking about your relationship with the pharmacist, That is another regulated healthcare provider. It has to be the pharmacist, not the pharmacy tech. But I think there could be some room to have a discussion around that as well, with them, to get them to come back to the clinic and maybe extend that prescription until you can do that.
Mhm.
But again, it has to be, someone has to have eyes on.
Yeah. And then I had another question regarding safety. So, I always encourage people, if they're living in rural and remote areas, that they should go with Suboxone because it is the safest thing to do. How do you ensure even safety of Suboxone? Because you don't really actually know. You're just basing it on what they tell you.
Like how much they're taking or using, like what specifically do you mean?
No, like safe storage of their medication to make
Oh,
sure
I
they're
see.
keeping it somewhere so nobody else is going to get a hold of it. Because I still want to ensure, even if a person's taking Suboxone, that a little kid's not going to get a hold of it, right?
Right.
So,
I guess you could get them to take a picture of the safe or where they're keeping it locked. If it's possible to do a home visit and safe to do that. I want to believe that people are telling us the best of their ability of what is actually happening, recognizing that that's not always the case. So I think you have to do your own sleuthing on that.
and then my final question was for methadone increases. Did they change that to 3 days or is it still 5?
Sorry, with methadone.
Like dosage increases? Because I know physicians will increase it as every 3 days or after 3 days. Or is ours still 5?
No, it has changed.
Okay.
Yeah.
Thank you.
Yes. And sorry, in regards to your previous question about the safety, I think also part of your responsibility is making sure you document those conversations in your EMR. So if you've told them to have a safe and they've told you that they have a safe and then something happens, then that's not on you. That's
okay. Thank you.
Mm-hmm.
We also will offer a lockbox to clients if they want it. And that's been helpful, just being able to provide that if they need it. But otherwise, yeah, we would just get like a picture or something just to show that they have a place to store it.
Okay, some questions from the chat. Are there nurses writing protocols for NLCP in group homes, or does the pharmacy provide the training and protocols? I don't know what NLCP means, so I can't answer this question unless you tell me what that acronym stands for. And is there a way to upskill to include SUBLOCADE prescribing? And the answer to that is the next part that the education committee is going to look at is DST for SUBLOCADE prescribing. I don't know when that will happen, but that was the plan. Any other questions? Yeah, go ahead, Tori.
Sorry, first day back after a while. I know that you said that clients need to be reassessed over the phone or in person prior to dose escalations. But I also know that in the new guidelines, there's like that kind of more rapid increase of Cadian, for example, like 2, 3, 4, like 100 a day. And I have worked with providers who are writing the prescriptions like that. Is that is not something that we can currently do? Okay, so
Right,
we are needing to check it.
Yeah.
Got it. Okay, thank you.
I would say that's technically recommended against in the guidelines for physicians as well. Now physicians get to use their clinical discretion.
Right.
the guidelines very specifically state reassess before any increases. So anyone who's writing automatically increasing scripts, that is outside the scope of the guidelines. Ideally recommended against, but obviously, in rural settings or settings with spottier access to oak care, then need to adapt to your situation.
Awesome. Thank you.
I don't know what her problem is, so.
There's a question about split doses of SROM, and is that in your scope? I don't think we addressed split doses. I think generally that is not in the new opioid use disorder guidelines. Is that right, Paxton?
It would be a pretty unusual form of prescribing for SROM. Not in the guidelines, no published literature on it. Unlike methadone, SROM has a fairly consistent half-life and is generally considered a once a day medication. It's also, given that it's 8 to 10 hour window to peak effect, it doesn't work particularly well for like PRN doses. So again, there may be some prescribers out there, or some patients for that matter, with take-home doses that may be doing that, but it's certainly not a guideline-based approach.
I agree. I think also not to confuse it with when there's drug shortages and we have to go to MS lawn, which does have split dosing because it is not a 24-hour formulation. So just to be clear, 2 different medications, 2 different half-lives and peaks. Did you have another question, Natasha?
I was just going to say the same thing about the MS lawn. Yeah, I do have another question. Do you typically see, so if people are on, and this might be like beyond me, but if people are on medications that increase the metabolism of their methadone, do you see an increase in their QT as their dose is increased? Or like from a physician standpoint, do you ever see anything like that? Or
I will say I've only seen an increase in metabolism during pregnancy. I've not seen it in any other cases myself. Paxton?
I mean, the QT would probably be the least of my concerns there. QT is, to a certain extent, a dose-dependent prolongation, but it's so variable based on an individual and when you're measuring the ECG and the heart rate and all those other things, that I think that the likelihood you'd notice that would be low. That's tiger country though when it comes, like when people are on those medications and they're on higher doses of methadone, just because if those medications do stop, whether they stop taking them of their own decision, whether somebody else discontinues them, it's really important that patients and other providers understand the significance of those interactions. I'd say most of the time they're maybe not theoretical, but the clinical implications are not huge, but there's certain medications where the clinical implications are quite significant, such that if somebody was to stop their medication, they could end up getting toxic from their methadone 3 or 4 days later. And that's so anyone who's on medications with the known interaction in terms of inducible cytochrome enzymes is somebody to watch very carefully and to make sure they understand not to make any changes to the medication without talking to you first.
thank you.
Desiree, you asked, well, we have guidance on MS lawn eventually, and I do believe there is some information provided on when there is shortages of SROM, how to go about MS lawn prescribing. So that's already included.
MS lawn is only indicated for Cadian shortages.
Yeah.
So it's just as a hopefully something we don't need to run into again in the future.
And then split dosing for methadone, though, is in scope for nurse prescribers. And I feel like we didn't address that So I guess if you're within the safe limit of 150 and following all the other guidelines, we haven't said it's out of your scope. And then just information about the COP is in the chat as well. All right.
I have one last question. Sorry.
Yeah. Okay.
So with this new DST coming out and the employer is going to be putting out their own policies regarding this, are we supposed to currently practice based on the old DST?
Right. So the new pieces of initiation is not within scope until your health authority has written their clinical practice standards about it. Yes. Which, if you're asking, is the case for Northern Health at present. Another question. Box 5 in the Suboxone DST states refer for initiations if the client has sedative use disorder or alcohol use disorder. Is this a new recommendation? I thought the previous DST was to consult. So the new DST has a lot more information on acute and chronic conditions. And so if the patient is stable and is using some alcohol, there is language around being able to prescribe for that. If they have a sedative use disorder or alcohol use disorder that is diagnosed and is not well managed, then that has to be consulted with another prescriber. I hope that answers whoever's question that was. Anything else? Yeah, Natasha, go ahead.
So regarding that and the conditions the people may have been diagnosed with previously, if the person is scheduled to come in because their prescription is ending and there is no access to somebody else to continue the script in that moment, should a person continue it until they can be seen by another prescriber at the same dose that they were currently on? Or would you
Sorry,
just stop it?
continue a dose of what?
Like methadone or slow release oral morphine if they have a pre-existing condition that is showing signs of being unstable. Like if there's no other option, what do you do in that situation?
I would call the 24/7 addiction medicine. Yeah. Yeah. Because I think for nurses, for me to give you a blanket statement about someone's stability is way outside of what anyone would be comfortable with. So you need to have that assessment, have some vitals, present it to a prescriber so that they can give you information in the moment, and help you weigh the risks of, their comorbidity as well as their substance use disorder, and which one needs to be treated more imminently. Yes, Claire?
Hello. I know you just spoke to this, but I just wanted to confirm. So I'm with the First Nations Health Authority. Do they need to write a DST for the initiation of methadone and strom before we can do it?
I don't know about the First Nations Health Authority. Is there anyone on here from their leadership team?
I can
Do you
also
know who?
reach out to them. Yeah.
Yeah, I would say reach out to Amber.
Yeah.
Yeah.
Easy. Thank you.
Yeah.
Yeah,
Oh,
sorry.
there's Amber.
I was trying to find. I have too many screens. Yeah, we could definitely connect offline at another time and discuss that and just describe the nuances of being from the organization that you're from.
Okay. Thanks, Amber.
No problem.
Maybe time for one more question. There's a question: if the organization would like to hold off on initiation of KDN and methadone, can a nurse prescribe? A nurse still prescribe. So you can prescribe, you can do the restarts within 30 days, you can do the pieces of titration, but until your organization has released something that says you are able to prescribe the new guidelines, I would check with them. Again, remember the kind of sphere that we work under is BCCNM sets out our scope of practice, BCCSU has written the guidelines, and then each organization really is responsible for how it rolls out within their own health authority and within which scope of practice they'd like their nurses to practice within. So they can't expand it past what BCCNM and BCCSU have said, but they can restrict it further. So I just really want to make sure you have those conversations with your own organizations. I can only speak on behalf of Northern Health. All right. Well, if there are no further questions, we will let people go. People who registered will get the recording, as they said. And I wish everyone a happy Monday. And remember, if you have time tomorrow, to tune into the OUD guideline webinar with Paxton, where he'll be in the hot seat.
Thank you so much, Ashley.
Take care.